Voy a volver a probar lo del puntero, un segundito. Le digo a los que están en Zoom.
Sí, doctor, adelante.
Ahí creo que funciona. Sí, perfecto. Ahora sí.
Ah,
Derecha, ¿verdad? Gracias.
todo excelente, sí, sí. Ya se ve.
Bien, bueno. Dejo de compartir y ahora sí estoy listo.
Vale, doctor. Me avisan que en 30 segundos ya estamos en directo.
Bien.
Vale. Bueno, muy buenos días a todos ustedes. Continuando con el programa de hoy, a nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, y chairman del World Congress of Neurosurgery, UNESCO ASPNet Walter y Dandy, in honor of Professor Yaşargil, a quien agradecemos por la organización de este magno evento, así como a la doctora Deyanira Casillas, chairman del capítulo ANSPNet, al doctor Salim Abdul Rauf, chairman y de Walter y Dandy Neurosurgical Society, al Dr. Babakatev, chairman de la Society for Brain Mapping and Therapeutics y de Brain Mapping Foundation, todos ellos vice-chairmans del comité organizador, y al Dr. Parménides Guadarrama Ortiz, chairman del Centro Especializado en Neurocirugía y Neurociencias México. Es para mí un honor presentar la siguiente ponencia a cargo del Dr. Federico Salle, presidente de la Sociedad Uruguaya de Neurocirugía, neurocirujano especializado en el área de neurocirugía funcional, enfermedades de Parkinson y movimientos anormales, neurocirugía de los trastornos psiquiátricos y dolor neuropático crónico, y máster en neurociencias y trastornos del movimiento de la Universidad de París. Adelante, Joshua.
Good morning. Continue with today's program on behalf of the UNESCO Ambassador Jorge Herrera Ramos and Chairman of the World Congress of Neurosurgery UNESCO ASPNet Walter E. Dandy in honor of Professor Yaşargil, whom we thank for organizing this great event, as well as Dr. Deyanira Casillas, Chairman of the ASPNet chapter, Dr. Salim Abdul Rauf, Chairman of the Walter E. Neurosurgical Society, Dr. Babak Katet, Chairman of the Society for Brain Mapping and Therapeutics and of the Brain Mapping Foundation. All of them vice-chairmen of the organizing committee, and Dr. Parménides Guadarrama Ortiz, Chairman del Centro Especializado en Neurocirugía y Neurociencias México. It is an honor for me to present the following presentation by Dr. Federico Salle, President of the Uruguayan Society of Neurosurgery, Fellow in Functional Neurosurgery at Henri Mondor Hospital in France, Master of Neuroscience and Movement Disorders in Paris University. Doctor?
Thank you, Joshua and Eduardo, for your presentation. Hello, everyone, wherever you are in the world. I'm very happy to be here. So I will share my screen with you. Before that, I would also like to thank the organizers of the Congress, and especially Dr. Solorzano for his kind invitation to participate. So let me know if you can see my screen.
Yes.
All right.
Yeah.
Okay, so during my talk, I will show you the experience we have in our hospital with the stimulation of the subthalamic nucleus in Parkinson's disease. And in order to do that, I will share with you a small study that we did with two groups of patients that were operated on with different surgical techniques. So to begin with, you know that there are many different ways to perform DBS. For instance, imaging can be different. You can use a stereotactic CT and fuse it with an MRI at 1.5 or 3 Teslas, or you can directly do a stereotactic MRI. If you have access to more sophisticated technology, you can even use intraoperative CT or intraoperative MRI. Then the type of anesthesia can also be different. The patient can be awake during the surgery. That's the most common thing to do. or you can also use general anesthesia. Some people argue that general anesthesia interferes with microelectrode recording, and of course you cannot examine the patient during the procedure. I will show you that microelectrode recording is perfectly possible under general anesthesia. And we will also talk about using or not electrophysiology in this surgery. In Uruguay, we began doing DBS in 2010. At that time, we didn't have microelectrode recording, so we operated the patient awake. We performed macrostimulation and clinical examination during the surgery, and we used CT fused with MRI at 1.5 Tesla, and we used the typical sequence T2 weighted images. Sometimes we also did stereotactic MRI. Then from 2017 until the present, we decided to change after my fellowship in France. And now we do CT, stereotactic CT. We fuse it with 3 Tesla MRI that we do to the patient before surgery, of course. And we use general anesthesia and microelectrode recording. So here you can see on the left the kind of images that we had at the beginning. That's a T2 MRI where the STN is kind of blurry. You cannot really identify its borders very clearly. Then at the bottom of the photo, you can see the patient is awake, cooperating with us. We are using macro electrodes to stimulate. Then on the right, you see the kind of images that we use now. The STN can be clearly identified. The patient is intubated, as you see here with the frame. And then we get this kind of microelectrode recordings. So as I said before, you can see that electrophysiology can be perfectly beautiful under general anesthesia. So just to let you know, this is a patient that we operated on recently. He's a 54-year-old male with Parkinson's. You can see in the preoperative video, he has some tremor and severe bradykinesia. You can also see that his gait is very impaired. He has a dystonic left arm. You can see he has a lot of problems turning as well. And then at day 3 post-op, you can see the other video. He raises from the chair perfectly. His gait improved a lot. And you can also see how he turns perfectly well. The bradykinesia got a lot better. And here's another patient with a severe tremor of the right upper limb and the chin. You can see when we turn on the stimulator, how the tremor almost completely disappears, and the patient is very happy. So the aim of our study was to analyze the impact of changing the surgical technique over the clinical outcomes. Basically, we compared efficacy and safety of both procedures. So we divided the patients in 2 groups. Group A included the patients that were operated on with local anesthesia and macrostimulation with MRI at 1.5 Tesla, T2 sequences. And group B included the patients operated on under general anesthesia with microelectrode recording and with 3 Tesla MRI, the FLAIR sequence that I will show you. So we wanted to compare motor performance between these groups. We also wanted to assess the motor benefit that the TBS is giving the patients at the last follow-up, just to make sure that the benefit is sustained in time. And we also compared the reduction in levodopa equivalent daily dose at 6 months post-op. We wanted to quantify changes in quality of life. In order to do that, we used the PDQ-39 questionnaire that you all know. And we also analyzed the rate of complications in both types of procedures. So basically, we included all the patients that underwent DBS between 2010 and 2019 for Parkinson's. Of course, they were all operated by the same surgical team, that's us, in Montevideo, Uruguay. And we excluded the patients that had undergone DBS less than 3 months ago, because they are obviously in a programming phase. Or also the patients who were unable to assist an appointment for a clinical evaluation in the off state were also excluded. So during this period of time, we had operated 23 patients. At first, in Uruguay, it was very difficult to perform this kind of surgery because the patient had to pay himself for the device. So it was very expensive and access to this therapy was very limited. Nowadays, we have an easier access and we are operating a lot more cases. So out of these 23 patients, some of them passed and other ones were lost to follow up, and we ended up including 15 patients. Both groups I already explained, group A and B. We compared their demographic features just to make sure if these groups were comparable at all. And we found that their age was very similar, the duration of the disease as well, and also the severity. You can see there that there's no statistical significant difference. So the groups were perfectly comparable. So as far as motor performance goes, we observed that in group A, when we turned on the stimulator, the UPDRS part 3 improved by 42%. In group B, we compared preoperative off state and the postoperative state with the stimulator on, and the improvement was 62%. And the same happened at the last follow-up. So this benefit was sustained in time. So as you can see, with the newer technique, our results seem better, even though when we performed a statistical analysis, we didn't reach significant differences, I guess because the samples are very small. However, when we included all the patients in one group, both A and B, and we compared stimulator off and on, we, with a linear model for repeated measures, we did find statistically significant improvement, motor improvement for all of our patients. Then concerning the reduction in levodopa dose, group B did better again, even though we could not reach statistical significance again. And concerning quality of life, remember PDQ-39 questionnaire, the higher the score, the worse the quality of life. So in group A, there were very different results. Some patients got better 88% or 66%, as you see there, and some other patients reported that their quality of life had gotten worse after surgery. So it was a very heterogeneous group. Then group B, it was better. I mean, they all reported a better quality of life after surgery. And when we compared, we found that the quality of life was improved by 60% in group B and around 24% in group A. That's an average. Again, not statistically significant. Regarding complications, surgical complications, in group A, we had one venous infarction with transient neurological deficit. The patient recuperated well after that. One electrode migration and one decubitus ulcer with local infection that required removal of the IPG. Then in group B, there was only one small bleeding in the trajectory without clinical significance. You can see there the CT with the bleeding. Regarding adverse effects of stimulation, They were pretty similar, a little bit higher in group A. We had one case of severe maniac behavior that required replacement of the lead. We actually switched it from the STN to GPI. And then 4 patients complained of dysarthria, which got better with programming. In group B, we also had one hypomaniac patient with severe dyskinesia that improved lowering levodopa dose. Another one complained of paresthesia and sweating, probably because we were too close to the red nucleus. But again, it got better with programming, and one case of dysarthria. So now let's discuss what are the ideal images, the ideal type of anesthesia, and whether we should use microelectrode recording or not. These are the images that we're getting right now. We use, as I said, a 3 Tesla MRI, and this sequence is called space flare sequence. You can see that the STN is perfectly identifiable here and here as well. So this is a paper published by the group in France where I did my fellowship that showed that 3D space flare sequence at 3 Teslas improves a lot subthalamic nucleus lead placement. And I'll show you why. You all know that T2 weighted images are the gold standard to target the STN. However, T2 weighted images, even at 3 Tesla or 7 Tesla, have spatial distortion because this is a gradient echo sequence. 3D space flare, on the contrary, is a spin echo sequence and is less sensitive to magnetic susceptibility artifacts and geometric distortion. Here you can see what space stands for. I could never remember that. And here are the technical parameters for the MRI. You can see it has a very long time of relaxation. So with space flare sequence, the borders of the STN can be identified 4 times better compared to the classical T2 sequence, as you see here. Also, if we compare the anatomical STN with the electrical STN, when you do your electrophysiology, you can see that the difference between them is less than 1 millimeter with the space flare sequence. And with T2, the difference is more than 1 millimeter. But what's more important is the clinical outcome. With flare, the motor improvement of their patients was almost 63%, and using the T2 sequence, it was 43%. Also, the total electrical energy delivered was lower. So they got 36% reduction, which makes the battery last longer, of course, and that's very important. Well, regarding the anesthesia, this is the anesthetic protocol that we use in our hospital. The group in France helped us a lot developing it, but basically it's a totally intravenous anesthesia with propofol and remifentanil. And it's very important to control the bispectral index during surgery, that it should be something between 50 and 70. Here is another paper that this same group published, and they showed that the type of anesthesia does not correlate with the clinical results in subthalamic nucleus stimulation. They included 54 patients, and they showed that the most important predictive factor for clinical efficacy is the length of the neurophysiological hyperactivity of the STN, and not the type of anesthesia. Actually, their patients operated under general anesthesia showed a 56% improvement in motor function, 65% reduction in motor complications, and 80% improvement in the activities of daily living. As far as microelectrode recording goes, here is a video of one of our patients under general anesthesia. You can see an STN recording that is perfect perfectly well, and we did not have any interference with general anesthesia. So as far as microelectrode recording goes, should we use it or not? Well, this paper was published something like 21 years ago by a very experienced group, and they said that the accuracy did not change, and they had more adverse events like hemorrhagic complications. But as I said, 20 years ago, the images were very different. The planifying softwares also were different. So I must disagree with that. There's another paper that showed that in this group, 30% of the times they changed the position of the lead according to the electrophysiology. So this group thinks it's very useful. And like that, you can find a lot of literature saying one thing or the other. Then nowadays, with the use of intraoperative imaging, some people say that microelectrode recording is no longer needed. I had the chance to use an intraoperative CT. This was the machine that we used in France. And of course, it was also associated with neuronavigation. And these are the kind of images that we get. So here you can see perfectly well your lead, the STN, and your position during surgery. So maybe with this type of technology, you will no longer need microelectrode recording. Here, I must agree with some other authors. And I performed this accuracy analysis, and really this type of technology is great and the accuracy is perfect. So the limitations of our study are very clear. We have small samples. This study is retrospective without randomization. There might be a memory bias in the assessment of quality of life. And there's also an influence of the learning curve upon results. So what conclusions can we draw from this? Well, I can tell you that we obtained good results with the use of 3 Tesla MRI and microelectrode recording under general anesthesia. The improvement in motor function and quality of life was superior with general anesthesia, even though we did not reach statistically significant differences. DBS lead placement under general anesthesia did not increase the rate of complications. So the fact of not being able to examine the patient during the surgery, it appears that it's not a problem, at least not in our experience. So this technique seems safe, effective, and more comfortable for the patient and also for the surgeon. I was just on the phone with a friend from Argentina who called me a couple hours ago, and he told me that he had a patient, a 70-year-old patient, that got really agitated during surgery, and that sometimes that happens. His blood pressure raised a lot. It was very high, and the patient has a small hematoma now. So I just want to tell you that you can think of this technique when you have some patients that might not tolerate awake surgery. This is an option, and it's safe and effective. Of course, larger randomized controlled trials are needed to determine which is the best implant technique. And probably each team should keep doing whatever they are doing if they have good results, and depending on the resources available at their hospitals. So that's all. Thank you very much for your attention. There's my email here if you want to ask questions. I'll stop sharing screen.
Thank you, Doctor. Well, we have no question in the comment box, but I would like to say that this was a great presentation, and I'm sure we all learned new things. And thank you very much, Doctor, for giving us a moment of your time to share your extensive knowledge. And I hope to have you here with us in Mexico for our next Congress.
That would be great, and thank you for this opportunity.
Thank you, Doctor. It's a pleasure for us. Thanks so much.
For me too. Have a